So welcome everyone to this ecancertv program. We are in San Francisco for the annual meeting of the ASH 2014. And my name is Prof Moreau. I'm based in Nantes, in France. And I'm happy to share this talk with you today with Mateos. You know her, she's working in Salamanca in Spain, with my very famous colleague Prof Stewart from Scottsdale, Arizona, and Prof Dimopoulos, who's working in Greece, Athens. So welcome everyone. And my first question is for you, Keith. You are one of the star of ASH 2014. You have presented a very important study in the relapse setting. So can you briefly summarize your results and your study?
Be happy to, Philippe. So our study was called the Aspire clinical trial. It was a large phase 3 clinical trial, 790 patients. And we tried to see if we could improve on the reference treatment of Revlimid and low-dose dexamethasone at relapse in myeloma. We tried to do that by adding the drug carlfizomib to the combination. The bottom line of the trial, I think there were 3 or 4 take-home points. The triplet combination of KRD, Kyprolis, Revlimid, dexamethasone, prolonged progression-free survival by almost 9 months, and had a 26-month progression-free survival, which really is somewhat unprecedented. Secondly, people went into complete remission 3 times more frequently than the control arm. Third, quality of life was better for patients taking 3 drugs rather than 2, which is somewhat astonishing.
Yes.
And then finally, I think this trial was very reassuring with respect to the safety profile of this combination, which really didn't send out any strong signals that we should be concerned about.
So that's a very, very important study. I know that Kyprolis is widely used in US, carlfizomib, but you know that in Europe, probably this study would be the pivotal one for the approval of carlfizomib. So from the European point of view, that's a very, very important study. And can you tell us about risk, the standard risk patients versus high risk patients? This combination is also effective for patients with high risk versus lenalidomide index?
Yeah, thank you for asking. We had high risk and saturated data on a number of patients. KRD, the combination, was maintained its superiority in the high-risk patients, almost as long as with the overall subpopulation. In standard-risk patients, it was even better. It was almost a 10-month progression-free survival, which is huge. Really amazing when you think about it. Unfortunately, in neither arm of the trial did the high-risk group perform as well as the standard. It remained higher risk by about 6 months, but overall, high-risk patients still benefited from the combination.
Okay, so thank you very much for this outstanding presentation. Many people in the audience were amazed by your data. And Thanos, you have also presented a very important study on pomalidomide and low-dose dexamethasone. And this regimen is widely used now in very advanced patients. So can you comment on your data?
Yes, Philippe, this was a phase 3B trial which included 700 patients, and the primary endpoint was to show that the safety of the combination of pomalidomide with low-dose dexamethasone was similar to that reported previously from the pivotal trials. This endpoint was met, so the primary toxicities were neutropenia with low rate of neutropenic fever and a low rate of discontinuation due to adverse events at about 5%. As far as response rate is concerned, it was confirmed that 1 in 3 patients achieved at least a partial response. The median duration of response for responding patient was 8 months. And responses occurred in patients who were refractory to bortezomib, to lenalidomide, or to both agents. Median PFS was 4 months, and the median overall survival was 12 months. Thus, it is reassuring that the pomalidomide low-dose dexamethasone can help significantly, approximately 1/3 of the patients with myeloma, and moreover, as we saw from other trials, it can be a backbone on which other regimens can be added. We know that there is experience with cyclophosphamide, with carlfizomib, with Biaxin, and also with monoclonal antibodies. So I think pomalidomide low-dose dexamethasone is an effective salvage regimen for patients with unmet need myeloma.
That's very important. Once again, thank you for this very interesting presentation. You were both speaking in the same session. So Marivi, you are one of the most important specialists, let's say, about the treatment of elderly patients. And that we can move now to the frontline setting. So you have presented the very interesting data on the sequencing of lenalidomide and VMP. I would like you to tell us about these results of what you are calling the total therapy for elderly patients. That's quite provocative. And maybe you can also comment another presentation that was presented by Cyril Hulin regarding very elderly patients above the age of 75 years treated by lenalidomide and dex or MPT.
Yeah, okay, Philippe. The first trial that you are mentioning, it has been conducted by Spanish myeloma group, and what we decided to do is to optimize the treatment of elderly patients with multiple myeloma. And as you know, VMP is one standard of care commonly used in Europe, and lenalidomide plus low-dose dex is the new standard of care for this patient population. So we plan to put both standards of care in this patient population, but not all together, but in a sequential or alternating scheme. So 9 cycles of VMP followed by 9 cycles of Lendex, or the same 1 cycle of VMP, 1 cycle of Lendex, and so on. And our hypothesis was that the alternating scheme would be superior to the sequential one due to early exposition to drugs with different mechanism of action. Mm-hmm. But the first conclusion of our study is that our hypothesis was not confirmed because the alternating scheme was not superior to the sequential one. And in fact, both arms were almost identical. But I think that what is much more important of our trial is that this combination, including a fixed duration of therapy, 18 cycles, including both VMP and RD, in a sequential and an alternating arm, resulted in a complete remission rate of 40%. 50% of these complete remission patients were in immunophenotypic complete remission. The median progression-free survival is about 3 years, with survivals superior to 80% at 3 years. And I consider that these results are in favor as compared with the standards of care used for the rationale of this trial, VISTA trial and FIRST trial.
And what was the feasibility in very elderly patients above the age of 75? And can you compare this with the data presented by Dr.
This is clearly relevant because, in fact, in our study, 50% of the patients were older than 75 years. And toxicity was higher in this patient population. And probably this is not very optimal for this very elderly patient population. And in line with this, Dr. Cyril Hulin presented this morning the results of the first trial, continuous treatment with lenalidomide plus dexamethasone versus RD18 versus MPT in really this patient population, very elderly patient population. And his results supported that probably this combination, continuous treatment with RD, is much more feasible for this very elderly patient population.
That's very interesting. So Len low-dose dex can become maybe in the near future in Europe at least the standard of care. We know perfectly that it is widely used in US already.
Yeah, of course. I think that at the moment of Lendex is approved in Europe, people would move to use this combination more and more because it includes just 2 drugs, and in fact it's of oral administration, and I think that it's specifically useful in this very elderly patient population.
So let's move now again to the relapse setting, and Thanos, we've heard this morning very interesting results with 2 monoclonal antibodies, 2 different ones in fact, targeting both CD38. What are you thinking about the results with SAR, the compound that was presented, the phase 1b in combination with lenalidomide and dex in very advanced patients?
Correct. So this was a phase 1/2 trial where patients previously treated with multiple regimens. Several of those were refractory to pomalidomide, to carlfizomib. All of them have been exposed to lenalidomide, to bortezomib, were treated with a combination of lenalidomide, dexamethasone, and increasing doses of SAR from 3 milligram per kilogram up to 10 milligram per kilogram. And the overall response rate was approximately 60%, which clearly shows that there is a synergism between this monoclonal antibody and lenalidomide with dexamethasone. And we envision that there will be other trials in that setting combining SAR with pomalidomide and low-dose dexamethasone, and also studies evaluating the role of SAR with lenalidomide dexamethasone in earlier phases of myeloma in the relapsing setting.
Yeah, so that's a very, very promising drug. And during the same session, we heard, Keith, about the other monoclonal antibody targeting CD38, daratumumab, also in combination with lenalidomide and dex in less advanced patients. So what are your thoughts regarding this interesting combination?
Well, I was very impressed by it. We have worked with the SAR antibody, but not yet with daratumumab. And the combination was very well tolerated, so that is not going to be an issue. Secondly, the response rate I thought was very, very promising. And I think it shows that these drugs are going to be, as Dr. Ola Langren told me yesterday, these are going to be blockbusters in myeloma. They are going to be used, I think, throughout treatment. Yeah. It's too early to tell which of the two is might have an advantage over the other. They both seem to be very good agents. Yeah. The one thing that I was a little bit struck with was the infusional related reactions with both drugs, but a little bit more with daratumumab perhaps, it seemed. Although I suspect those are very manageable in clinical practice. I don't know what experience others have.
You have tested daratumumab frontline. I mean, we have heard about very advanced patients last year at ASCO, for example, in refractory patients, single agent. We are hearing now about Lendex plus Dara or SAR in the relapse setting. But Marivi, you have the experience of Dara frontline, especially in combination with VMP. So what do you think of this combination? We are going to have this R-shop for myeloma in the future. And what about the toxicity?
Probably, although it's too early to confirm this point, but you know that there is a phase 1b trial in which daratumumab has been combined with different backbones treatment in first-line of therapy, including bortezomib plus dexamethasone, bortezomib, melphalan and prednisone, and bortezomib, thalidomide and dexamethasone. From my personal point of view, the first important point is tolerability is perfect, because concerning safety profile, just to know few infusion reaction, but most of them occurred during the first infusions.
And mostly grade 1.
So no hematological toxicity, no non-hematological toxicity, and I think that is important. So tolerability is perfect. Of course, in terms of efficacy, I think that we have to wait, because now we can advance 100% of overall response rate, but very few patients have been included in the trials. But I think that the point of starting phase 3 randomized trials in which daratumumab will be added to these backbones, but in randomized trials, and we have to wait to obtain consolidated results. But of course, I think that in the near future, the monoclonal antibodies can be the backbone of the therapy.
Okay. So if I can summarize, I think that we have very interesting data in pomalidomide in very advanced patients, confirming trials, in fact. And Keith, you presented outstanding results, to my opinion, with carlfizomib in the relapse setting in combination with Lendex. We are improving as well with novel agents such as monoclonal antibodies targeting CD38, SAR and DARA. And as part of frontline treatment, we have for sure the confirmation of the feasibility of len low-dose dex in very elderly patients. And maybe for a subgroup of patients younger, the addition of Lendex plus VMP could be a very interesting option with a very good progression-free survival, as you mentioned and as you described today, Marivi. So thank you everyone for this very interesting presentation, and well, see you soon in another meeting.